We're going to be moving into our next session, which is our medical panel. So we have Dr. Omolara Lawal. I'm going to welcome her on up. Come on up, Dr. Lawal. And Dr. Ryan Brennan, who will be joining us up here as well. Super. Thank you. So, what we did this year is a little bit different. Instead of just having us talk, we decided that when you registered, that we would ask you questions. What do you want to ask our medical panel? And so that's what we're going to do today. Is we're just going to kind of read off some of those questions that came in from you so that we answer some of those questions. So it's not a canned talk. It's really us sitting down and having conversations about those questions that you submitted. Dr. Omolara Lawal earned her medical degree from Lagos State University College of Medicine and completed her residency in neurology at Penn State Health, Milton S. Hershey Medical Center. She completed her fellowship training in movement disorders at the University of Maryland Medical Center and is certified by the American Board of Psychiatry and Neurology. Dr. Lawal is a fellowship-trained and board-certified neurologist caring for adult patients at the Prevea Allouez Health Center in Green Bay. She specializes in Parkinson's disease, including skin biopsy testing for Parkinson's diagnosis, tremor, dystonia, Botox treatments for dystonia, adult tic disorders, abnormal movements, memory concerns, gait problems, deep brain stimulator assessment and programming after surgery, and assessment for anti-amyloid therapies for cognitively impaired patients. She believes that putting the patient first is the key to maintaining a good quality of life for her patients, which is something that she strives for daily. Dr. Ryan Brennan was born and raised in Kalamazoo, Michigan. He graduated from Michigan State University with a bachelor's in science and later his doctor of osteopathic medicine. While he worked in Parkinson's disease, was working with Parkinson's disease in the laboratory, and then he went on to complete his residency in neurology at the Medical College of Wisconsin, after which he completed a 2-year fellowship in movement disorders at the University of Nebraska Medical Center in Omaha. He practices now at the Medical College of Wisconsin and specializes in movement disorders, including Parkinson's disease, using pharmacologic options as well as Botox injections. And he also performs deep brain stimulation as well as utilizes the Duopa pump. Please welcome Dr. Laura Lawal and also Dr. Ryan Brennan. And I'm going to join them over here because I feel like we should have a glass of wine and a fire or something, right? All right, so the first question that was submitted says, how do you help a person with Parkinson's who feels like they may be unable to swallow food and the food is in their mouth, but they don't remember how to swallow? So I'm actually going to toss that to Dr. Lawal first, if you don't mind.
Thanks, Dacy. Thanks for having me. It's a pleasure to be here. So swallowing problems are pretty common in Parkinson's, and it progresses as the disease progresses, of course. For this patient in particular, one question I will ask is, did you ever have a swallow evaluation? In my practice now, I don't know if Dr. Brennan does that. I've started doing like a baseline for my early Parkinson's. So when I see them first, I like to get a baseline so to compare later on, because the disease will definitely progress and I want to have something to compare with. So if the patient hasn't had that, I think the next step will be to get a swallow evaluation in which we would have a camera placed to assess how you swallow. So it's a video-assisted swallowing procedure. So that will be very important to get done now. And at this point, there will be need for what we call speech therapy, in which speech will teach you how to employ maneuvers that will help you swallow better, and setting cues such as I know they do the chin talk to kind of teach you how to move your neck in such a way that it helps swallowing easier. Also, you may require a specific consistency of food, maybe not the regular food you eat. You may need to have soft diet or something adjusted in your diet to make it easier to swallow.
Super. Dr. Brennan, do you want to add anything to that?
Yeah, I would just agree with Dr. Lawal that swallowing problems are very common for people with Parkinson's disease. The best way to really understand what's going on is to obtain that video fluoro swallow study. So if your doctor is recommending it, it's a very good idea to do that. And the speech therapists typically perform those, and they can really see where the issues arise. One part of this question, they comment on they have it in their mouth, they're chewing, but they forget to swallow. And that can be from some of the cognitive impairment that's also common in Parkinson's disease. But really the best way to address those issues is getting that evaluation done and then working with a speech therapist following that.
Super. What do you think as far as, so they said that the food is in the mouth, but, they're just not swallowing. Could that be part of a memory issue as well?
Yeah, Parkinson's patients have different issues with cognitive impairment, but one of them is multitasking. So particularly if you're at the dinner table, conversations going on, it may be challenging for them to both participate, concentrate on the concentration of the conversation, and also remember to do what they need to do in terms of swallowing.
And so if that was part of that evaluation, then what would you do as far as any memory testing and things? How would you assess that piece if it was really not necessarily the swallowing mechanism, but it might be more of that memory piece? What would you do in your clinic?
Again, speech therapists can work with patients with cognitive impairment, so I would probably start there. If there's other memory issues or concerns going on, we could evaluate that further.
Good. We love our speech therapists. They're fantastic. And actually, speech therapists are also memory therapists. So it really kind of goes hand in hand. So those speech therapy referrals are really important. Thank you. So our next question is stem cell treatment successful? And I'm going to give that to Dr. Brennan.
As of right now, stem cells for the treatment of Parkinson's disease remains experimental, meaning it hasn't been proven to successfully treat Parkinson's disease. That being said, previous trials that were not successful, there is still an ongoing interest for that. And I think it gets into our second question. Sorry to jump ahead, if you don't mind. I'll just kind of... I'm aware of 2 clinical trials going on in the United States right now. They're both a little bit different, where they actually inject stem cells into the brain and then see if they can help produce more dopamine for patients with Parkinson's disease. But at this time, it's not a proven treatment. And we're excited. My partner, Dr. Kunal Gupta in neurosurgery, was able to bring one of those trials to Froedtert in the Medical College of Wisconsin. So we're hoping to open that study later this fall.
Dr. Lawal, do you have anything to add to that? Yeah, I completely agree with Dr. Brennan. It's purely experimental right now. So I know there is some commercially offered stem cell therapies for Parkinson's disease. In the movement disorder world and in neurology in general, we do not recommend that, except it's a part of a clinical trial. It's all purely experimental for now, not yet FDA approved.
And then, so Dr. Brennan, when you mentioned that Dr. Gupta was looking into that, how would people find that information out if it did become available to them? We
can't really speak to it right now because it's not open. But I can check with Michelle. I see you standing in the back. If Marie, our research coordinator, left some contact information. Again, it wouldn't be worthwhile to reach out to us right now, but in the fall, you could reach out to our research coordinator, Marie Majacki, and she'd be able to give you information on that. And we could potentially, do a consultation to see if someone would qualify for that. But we're very excited to bring that trial here to Wisconsin and offer that to patients that may be interested and qualify. But just to reiterate what Dr. Lawal said too, I didn't touch on is, there's a lot of different other non-clinical trial companies, places that report, they offer stem cell treatment for Parkinson's disease. And as she said, those are not FDA approved or proven treatments. And I do the same with my patients. I don't recommend those types of treatments unless someone's going to participate in a bona fide clinical trial for which they don't charge you for that treatment because it is a clinical trial and it's under IRB oversight.
I agree with that too. I actually had visited a support group probably about a year ago, and a woman and her daughter were at that support group, and we were talking about stem cells and how it's really just not something that's readily available. But they had actually gone to a hotel where they were offering stem cell injections, and they had just done this the week before. First off, a hotel should be a red flag, But I mean, people are doing it, and that's why I mention it. And I've had a number of even my own patients say, hey, this place is offering it. If it were doing something, we'd all be doing it. If it was really going to reverse Parkinson's, that would be mainstay with your movement disorder specialist. So even though that might sound odd, some of the places that people are doing the stem cell injections are iffy, and they spent $25,000 to do it, and they were considering doing it again. So there are scams that way too, and you should be aware of that because they're out there. So we're going to move on to our next question, and it says, do your hands tremor when you're sleeping? And I'm going to give that to Dr. Lawal.
So tremor is a hyperkinetic movement disorder there's too much movement. Typically hyperkinetic disorders, they should not typically happen when you're sleeping, but there are different stages of sleep. You have the lighter sleep stage and you have the deeper sleep stage. In the lighter sleep stage, you are likely to see maybe a little bit of tremor, but it should be less than when the patient is awake. However, in deeper sleep states, you should technically not see tremor. So I hope that answers the question.
Dr. Brennan, did you want to add anything to that?
I completely agree. And the majority of the sleep stages, someone won't be tremoring. But in those lighter sleep stages or transitions of sleep, people can experience some tremor. Also, if you wake up, have to use the restroom in the middle of the night, medications have worn off, you may have some tremor come back at that time. But when you're fully asleep, there's typically not a tremor.
Right, so you might think, I've heard too before, people have said, oh, my tremor woke me up. Well, you were in a lighter state of sleep, and then it can wake you fully, definitely.
Correct.
Good, super. So our next question is, does any Parkinson's medication cause itching? Dr. Brennan, I'll give that one to you.
Not the most common side effect I hear. I think any medication potentially could, or non-active ingredients, the dye they use. Some people may be more sensitive, but it's not something. I don't think I've heard a patient report that with at least most of the mainstay Parkinson's disease medications. Dr. Lawal, have you encountered that?
Yeah, I agree with you. It's a rare side effect of the dye sometimes. That's the yellow dye with the carbidopa, levodopa. Otherwise, the only association I can think of is seborrheic dermatitis, which is a kind of skin condition that occurs sometimes in patients with Parkinson's. and it's from the autonomic dysfunction. The glands which produce the oil in the skin may not function as well because things are kind of disrupted in Parkinson's due to dysfunction of the nerves. So the glands don't function well. Sometimes you have too much oil being produced. That causes a kind of dermatitis. It's not very common, but people do get it. You have this flaky redness of the skin, basically very dry skin, which may cause itching. So apart from that, I don't really see itching being a direct consequence of the disease.
Super, thank you so much. The next question is a little bit about vision. And so it says, how common are vision problems associated with Parkinson's disease? And what types of problems are seen and how are they treated? So it's a lot, but let's just start with what kind of vision problems do we notice with Parkinson's? Dr. Lawal?
So what comes to mind first is dry eyes, really, and that is primarily from reduced blink. A normal person should blink, I think, up to 20 times per minute, thereabout. But with Parkinson's, there's reduced blink, and you subsequently have a lot of dryness of the eyes. So that's the main thing. And when the eyes are very dry, you may have blurry vision, which happens quite commonly. Secondly, dopamine is very important for eye motility. So for your eyes to move well, to look to the right, to the left, you need dopamine. And if you don't have enough dopamine, your eye motility is affected. And that's when things like double vision starts coming into play. Also, some Parkinson's patients notice difficulty with reading. They have trouble following the thread of the words. It becomes more difficult for them to just read like a complete line easily. That's another problem we see in Parkinson's. And I know that with Parkinson's, we also see what we call blepharospasm, which is basically your eyes shut on themselves without you shutting your eyes. So it's an involuntary closure of the eyes. That may happen. That's also similar to what we call eyelid apraxia, in which your eyes also close by themselves without any prompting from you, basically. So those are some of the common things we see. Hallucinations can also happen. That is also tied to cognition in some way. I think those are the ones I can recall off the top of my head right now. Dr. Brennan will jump in to help me.
I think the biggest thing with eye or vision issues, directly related to Parkinson's disease are going to be the movement, that eye motility, moving your eyes across the page when you're trying to read, and they don't move as smoothly as they used to, or they start to separate a little bit, and that can cause the issues with double vision. In terms of treating that, I don't have a lot of patients report that it necessarily gets better when they take, their Parkinson's medications or their carbidopa, levodopa. I typically will have patients see a special ophthalmologist called a neuro-ophthalmologist, where they have training in both ophthalmology and neurology to help, fully diagnose what the eye movement issues are. And if there is anything that can be done to help that, particularly with a prism lens that can help align the light as it comes into both of our eyes to help mitigate double vision. But also, all of us can experience regular everyday vision issues. Cataracts are more common as we get older. Visual acuity, like myself, I need some pretty strong glasses so I can see. So making sure that we're not missing any of the normal everyday things that can impact people's vision.
Have any of you followed our Pearls for Parkinson's? Is that something you've been watching? So on our website, we have a series called Pearls for Parkinson's, as well as on Facebook. And we did hit vision problems in there as well. So there are a few of like the double vision and depth perception and things like that. So if it's something that you haven't looked at, go ahead on our website, on our WPA, it's wiparkinson.org, and those are pearls for Parkinson's. And so let's move to our next question. This one says, I was diagnosed with PD in 2011, and it's been a slow progression like they said it would be for many people. But in the last 6 to 9 months, I've been having balance problems and would like to know what advice you can give to help us with balance issues. I'll give that to you, Dr. Brennan.
Balance is tricky. For us to walk upright on 2 legs, it takes a lot. Muscle coordination, sensing where your body, your arms and legs are in space, and your brain's ability to receive those signals. In general, as we get older, our balance tends to not get better, it actually gets worse, even for people without Parkinson's disease. And then you throw Parkinson's on top of it, and it just adds to it. Some of the walking issues that people have that start to impair their balance may respond to their Parkinson's disease medications or treatments, but not necessarily completely. And so really, one, staying active, exercise is a huge part of, maintaining the strength in your legs. But also, very early on, if you're starting to notice just subtle changes, getting in to see a physical therapist for an evaluation is start working on things that can help at least maintain your balance abilities. And then as things progress, because we don't have really good treatment specifically for, balance impairment, is, continuing to work with physical therapy, but also, consider and be open to the idea of assistive devices, such as canes or walkers, that can help prevent falls and prevent, serious injuries.
Dr. Lawal, do you want to add to that?
Yeah, just to piggyback on what you said, I find out that people use different words for my balance is not good. So if a patient comes to you and says, oh, my balance is not good, and when I try to probe more, I find out that maybe they're dizzy when they stand up, or maybe they're freezing when they walk. So sometimes it's very important to be very specific about what symptoms you are having and what exactly you mean by my balance is off.
What about neuropathy? Can they have neuropathy along with Parkinson's, and would that affect balance?
Yeah, just as I mentioned, like getting those signals back to the brain so you know where your feet are when you're taking a step. Neuropathy, common just in general as people get older, but even more so with people with Parkinson's disease. Sometimes, so speaking with your neurologist, making sure there's not a treatable cause for the neuropathy. Sometimes we can find that and address that to at least keep it from getting worse. But we may not be able to prevent that, but it's just one of those added factors in that can further impair balance.
And I think that's why, too, we incorporate and we talk so much about this movement. You had mentioned about physical therapy and how important that is. I think especially if maybe you're not as active. I've had people that have said, I don't exercise and you're not going to make me. And unfortunately, exercise is one of the best ways to improve balance. And sometimes going to the exercise groups can seem scary, and one of the nice ways of maybe weaning into that is through one-on-one physical therapy to actually get that confidence level up, and then to transition yourself into a group program so that you keep it up. Because just like anything else, your balance can get better with therapy, but then when you go home, if you don't do the work, if you don't practice what they give you for exercises, or then transition into an exercise a community exercise program, you're going to regress again. It's going to decline again. And you had mentioned about different devices. I think I'd love to give Joy Explorations a plug too for the urban poles, because that's another option that you can use, the urban poles. For those of you who aren't familiar, Joy's out there, and she's the first one by the door, and she's got poles that can really help with your balance and your walking as well. So, anything else you guys want to add? No? Super. Our next question is there a comprehensive functional assessment for Parkinson's? What would the categories important to assess and keep measure of? And, when we were kind of talking about this, it was like trying to hone in on that question a little bit. And I think when we think of Parkinson's assessment, it's really about kind of what we do in the clinic. So Dr. Lawal, I'll let you answer that one. What kind of functional assessment do you do?
So we have a general one that we use, which we call the Unified Parkinson's Disease Rating Scale. We call it the UPDRS. We have an older version and we have a newer version. The newer version is called the MDS UPDRS, which is the Movement Disorder Society UPDRS. The first and the second are basically the same, very similar, just a few extra things added to the second newer one. But the aim of this rating scale is to assess patients' progression over time. And it's divided into 4 parts. The first part has to do with your cognition, your mood, that is, each of these things we assess for, like we assess for your memory. We assess if it's normal, if there's a mild decline, moderate or severe decline. And we do that for your mood as well. And that's the first part. The second part basically is at your ADLs, which is your activities of daily living. So things like showering, things like hygiene, things like how long does it take you? Would you take longer to cut a piece of steak or cut food? Just assessing how you do day to day, your activities. And the next stage is the model exam, which is where that's what we mostly use in the clinic. It assesses for many things such as tremor, bradykinesia, which is basically slowness of movement, and we also assess for rigidity, and I think that's most of it. Yeah, basically how slow the individual is. And the last part has to do with the complications of therapy. If you're having dyskinesias, which is being squirmish, if the medication is wearing off, things like that. So those are the 4 different parts. And as I said, it's basically to assess disease progression. So let's take, for instance, the model UPDRS. If I see a patient for the first time and I do the model exam and I score maybe 10 on the model exam, the next time I see the patient, I anticipate, or my hope is that I'm not going beyond 10 or 11 or 12. If it's more than a 3-point increase, then I'm wondering, is the medication optimal? Are you taking your medication well? Is the medication being absorbed well? Kind of try to optimize therapy. So it's just to assess how the patient progresses over time.
So parts 1 and 2 are really kind of something we use in our questioning, in our conversation more so. You're coming in and, we're asking you how you're doing at home and kind of seeing where the strengths and weaknesses are. Really, it's kind of more of a verbal communication. And then that part 3, the motor exam, is our exam that we're doing in the office. I thought it would be kind of fun to show people what that is. I don't know, right? Because we make you, all of you, you're sticking your hands out, right? We're making you tap your fingers and tap your toes and all that stuff. You probably don't know what we're doing, right? Unless we really kind of explain that a little bit. Why don't we explain it to them a little bit? How's that sound?
You're my patient?
Okay.
You can sit there. So the first parts are just kind of getting a general assessment of how are they moving, how are they sitting, are they adjusting themselves, and really in particular the first one is facial expressions. So is there reduced blinking like Dr. Lawal talked about? Is there reduced expression? Maybe there's a joke between you and there's a little bit of delay or less of a facial response with that. So it's just an observation. Second is speech. So a lot of times we pick up on that just with our normal conversation, like we've been talking up here, but I may ask someone to repeat a phrase like, "Today is a sunny day."
Today is a sunny day.
And you're assessing for how clear that comes out. Is it slurred? Do they have hesitations in there? Is it hard to understand someone? And then based on that, we'll grade that. The next part of the examination is rigidity. So we look at the neck, head and neck, both extremities, and the legs. Hard to do with the microphone, but we're assessing both arms moving in the moving a couple of different the joints in the full range of motion, assessing if there's any of that stiffness or if we can't get all the way to that full range of motion. And we'll do all of that, like I said, thank you, for the head, the neck, the arms, and the legs. Then we move on to our bradykinesia examination. So Dacy, with your right hand, can you tap your finger big and fast? And we're looking for the movements that start to slow or pause like she did there. Sometimes they freeze. The next part I'll have you do is open and close your hand. Again, looking for the movements if they're getting smaller and slower, or those hesitations or pauses, or in really severe Parkinsonism, someone may not barely be able to do that at all. Next part in the upper extremities, we look for is pronation and supination, and then we move on to the legs with toe tapping, and then stomping of the leg. And then we start to test balance. We start to assess this with if you can stand up without assistance. So if you could cross both arms across your chest and stand up from this very low chair. Once we have someone standing, then the way I do it is I'll assess their walking. So we usually step out in the hallway. I'll watch them, walk 10, 20 feet, come on back. You're assessing if there's any hesitation, balance impairment, just with regular walking. Do they require a walker or a cane? And is there any freezing? Then we check the balance, in which this is everybody's favorite test. So you have someone take a nice steady stance. You come around behind them and you say, "I'm going to pull you backwards." And I tell patients, don't trust me. Pretend you don't trust me. And when you're falling back, I want you to take a step back and catch yourself. And this is a good measure of how impaired someone's balance may be. Now, I don't let patients fall if they do have trouble. That's why I'm behind them, and I'm there to catch them if they have issues. All during this time, we're also assessing if there's tremor, but we'll come back in the room. We start with a postural tremor. Dacy, if you can hold your hands up and spread your fingers apart a little bit. Typically with Parkinson's, there won't be a tremor right away when people move their arm, but it may come out. And then we test for a kinetic tremor. If you can touch my finger, touch your nose. Good. And we do that on both sides, obviously. And then if I'm not seeing a resting tremor, we'll do some additional tests, just having someone sit nice and relaxed in the chair and assess their tremor. One, how severe it is, but also how much of the visit time that resting tremor is present. So that is the overview of the Part 3 MDS UPDRS. I think I remembered everything.
And obviously that's important because we do that as a baseline, right? So maybe at the time of diagnosis or the first time seeing the patient, they may be on medications, they may not be on medications. And we're looking at, like Dr. Brennan said, comparing each side of the body to see what limbs are affected, right? And then taking note of that. And then if we do treat or make medication changes, what changed what improved or maybe didn't improve, so that we have, an exam to go with it. And so some of the things like the rigidity, when you said, you were moving my arm around and testing to see if there was like any cogwheeling or anything, how would that person feel? What would they report if they felt that?
Typically people don't specifically feel the rigidity, at least that's my take on it. What they feel is this slowness, so the slower movement, more difficulty with movement. They may feel more stiff in general. A lot of times an early sign of Parkinson's can be shoulder pain or hip pain because of the muscle stiffness. But a lot of time, I don't know, Dr. Lawal, do you feel like people feel the rigidity?
No, I agree with you. A lot of people don't even know they have rigidity until we do the testing. But yeah, they may report, I feel stiff, or when I wake up, I really have a hard time getting out of bed, or my hand gets stiff towards the end of the day, things like that.
Or they might have a hard time getting their arm up to comb their hair, that range of motion would really change. And even like getting your foot up and down a stair, up and down a curb, or in and out of the car, oftentimes if that's reported, we kind of feel that stiffness on our exam. And so if we're making a medication change, we might then ask, well, how is it getting in and out of the car? How is it getting up from a chair, or up and down those stairs? Or now can you comb your hands? So some of those things that people report can kind of correlate to that part of the exam, right? Mm-hmm. Mm-hmm. So I guess, when you're even first diagnosed, you're trying to pay attention to what's supposed to happen when you're treated, right? And it's important to kind of know where those strengths and weaknesses are in the exam so that you know what to report back, right? Anything else that you guys wanted to add to that?
Yeah, I would just say, most movement disorder specialists will do the part 3 when you see them in a normal clinical encounter, particularly the first time you see them, or if making a major treatment change and trying to assess follow-up, benefits of that. The other parts, at least in my practice, I don't regularly do those. I think we touch on all of those aspects with the normal questions that we do, but I'm just not doing it in that formal, standardized fashion, with the exception being in clinical trials. So Parkinson's disease, clinical trials with drugs or stem cells, whatever it may be, they're going to do all 4 parts of the UPDRS when you see them. Not necessarily, a functional assessment that patients need to do outside of those clinical settings. But there are other ones your doctors may ask you to do, such as a Parkinson's disease motor diary, where you track, what symptoms get better, or when the meds are working, when they're not working over the course of, 2 to 3 days, so your doctor can then better assess your treatments and if adjustments to that treatment can be made to smooth out control of your symptoms.
Thank you. We've got enough time for one more question. So what about updates on medications? Anything new in the realm of new medications? Dr. Lawal, I'll let you start.
Well, we have new formulations of levodopa. We have the new subcutaneous levodopa, carbidopa, that was just approved, I think it was approved late last year. And basically, what I tell my patients is that it's like an insulin pump. It's just a subcutaneous delivery of the same medicine you're taking. And with that, the good thing is that you don't have to worry about, your food. Do I have to eat? No, not eat before it. That can be quite cumbersome for a lot of people. However, there are certain criteria to fulfill before you can have that as a form of therapy. And I know that the second subcutaneous therapy, the apomorphine, was recently approved in the US. It's basically a dopamine agonist that is in liquid form. That is, if you are on like pramipexole, it's kind of in that, or ropinirole, it's in that class of medications. The only new medication that I know about, it's in clinical trials right now in the UK. It's called Ambroxol. It's supposed to modify the disease progression. Ambroxol is interesting because it's actually a cough medicine used in the UK. We don't have it here in America. It was initially developed for a particular class of Parkinson's disease patients, that is GBA patients. It's meant to increase an enzyme in the brain which helps to clear the abnormal protein that Parkinson's produces, which is alpha-synuclein. It works pretty well. They have pretty promising studies. However, it's still in the phase 3 clinical trials. One of my patients actually went to Mayo Clinic and they had recommended it. He couldn't get it in the US. He had to get it from Germany or something like that. However, it's not yet approved. It's still in clinical trials, but it looks quite promising, and I'm quite positive, or I'm trying to be positive that this is going to work. I think that's the only one I know right now that is in clinical trials.
Dr. Brennan, any more you want to add?
I think, yeah, the biggest things that have come out recently are those subcutaneous infusions. Not something people early on in the course of Parkinson's disease need to worry about, but further on down the road, if people are having a lot of the fluctuations, dyskinesias, trouble getting the right dose with the oral medications, the infusions can definitely help. So I think it's good that those options exist for those patients now. And yeah, more recently, the apomorphine was FDA approved, which has been available in the UK, I think, since 2016, 2017. Other than that, there's a new extended release form of carbidopa, levodopa in a capsule. There was Ritari, which has been out, I think, since 2015. The same manufacturer of that came out with a little bit different formulation of that. Again, all of these minus apomorphine, are just different forms of carbidopa, levodopa, but it has been shown to last longer. So those are the main approved new treatments that are out. As Dr. Lawal mentioned, there's a lot of ongoing research, still trying to find a treatment that can slow the progression, which we haven't found yet. And I think, there's more coming out now looking at genetic subtypes of Parkinson's disease, which still make up the minority of all of the people with Parkinson's, but starting to study different treatments and medications specifically for those subtypes of Parkinson's that we're optimistic will show some benefit for those patients.
Super. Thank you. We're going to wrap things up. I'd like to give a special thank you again to Dr. Lawal and Dr. Brennan. Let's give them a warm hand. Thank you.